Hello and welcome. I'm Dr. Ajay Singh. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's CMEO briefcase entitled Challenges in Anemia in CKD. Today's program is supported by an educational grant from GSK. Just to go over my introduction and background, I'm a senior nephrologist at Brigham and Women's Hospital, and that's in Boston, and Senior Associate Dean for Postgraduate Medical Education at Harvard Medical School. Let's just go over the learning objectives for today's presentation. The goal of this activity is to utilize the latest data on novel therapies in clinical decision-making to address unmet needs in the treatment of anemia due to CKD. And what I'd like to do first is to showcase this discussion really with a case, and the patient's case is as follows. Eugene is a 65-year-old male who presents for discussion regarding treatment with erythropoiesis-stimulating agent, or ESA, and for the adjustment of iron supplementation. Eugene's past medical history: he has end-stage renal disease, he has type 2 diabetes, that's the cause of his end-stage renal disease, anemia, and chronic kidney disease. He's a person of African-American descent who presents with a past history also notable for a hospitalization due to infection recently, which was treated with intravenous antibiotics. He undergoes dialysis at home 3 times a week. His lab findings are shown. His hemoglobin is 9.2 grams per deciliter, a serum iron of 42, transferrin of 470, an iron binding capacity of 588, and a serum ferritin of 10 nanograms per mil. This all translates into transferrin saturation, or TSAT, of 7%. Now, it is important to recognize that his hemoglobin level of 9.2 is below the usual threshold for optimal control of his hemoglobin. The FDA guidance would say that the hemoglobin level should be between 10 to 11 grams per deciliter. And depending on the guideline you read, whether it's the European guidelines or the KDIGO guidelines, most guidelines will say keep the hemoglobin above 10 grams per deciliter. The European guidelines say keep it below 12, and KDIGO is 10 to 11 grams per deciliter. So he's below the target hemoglobin that we expect him to be at. The other important point here is that his TSAT is 7%, and this 7% is lower than what guidelines would suggest is satisfactory. Guidance says keep the TSAT at around 20%, and 7% is obviously much lower than that. The data also suggests that the source of this iron deficiency, if you will, is a reduction in iron stores, because as you know, ferritin is a very good measure of body stores of iron, and his ferritin level is 10 nanograms per mil. The guidance would say keep the ferritin level above 100 nanograms per mil. So this is a person, I think, who's clearly anemic. The anemia is most likely because of iron deficiency, and iron deficiency, not just a deficiency in availability of iron, which can sometimes happen in inflamed patients, but a deficiency in total iron stores. Let's now look at the pathophysiology of the anemia of chronic kidney disease. On the left-hand side, what you see are some of the factors that lead to anemia in patients. Probably the most important factor is erythropoietin deficiency. As most of you know, erythropoietin in adults is produced in the kidneys by proximal tubular epithelial cells. And there's a response to reduce oxygen as measured by hemoglobin circulating around that triggers erythropoietin release. But in general, though, the cause of anemia of CKD is actually multifactorial. Patients who have chronic kidney disease on dialysis, or even those not on dialysis, are generally inflamed, and this inflammation reduces erythropoietin production and also red blood cell lifespan. Second, excess hepcidin impairs iron absorption and mobilization of iron body stores. it's important to note that hepcidin, a protein that's secreted by the liver, is excreted by the kidneys. So, and that high hepcidin levels, elevated hepcidin levels, lead to an impairment of absorption of iron through the GI tract. So, as kidney disease progresses, hepcidin levels in the blood increase, and hepcidin in elevated levels reduces absorption of iron. And last but not least, blood loss from the process of dialysis can also be a factor. And indeed, blood loss from frequent blood draws are also a factor as well. On the right-hand side, what you see is a schematic that demonstrates some of these factors weaving with each other. There's disrupted renal oxygen sensing. This is because of the kidney becoming diseased. Proximal tubular epithelial cells are not effective in sensing reduced oxygen, and there's reduced production of EPO. There's inflammation that results in reduced EPO production, reduced red cell lifespan, and excess hepcidin for the reasons I've already discussed. And of course, you can't walk away from the importance of uremic toxins, which also play a role in creating a milieu that reduces erythropoiesis, but also reduces lifespan of red cells. All of this play an important role in causing anemia. On the side, you see the left-hand side, you see blood loss, which we discussed through either the dialyzer or through frequent blood draws. And on the right, iron deficiency, either functional or relative iron deficiency, because the iron is not adequately mobilized, it's stuck in storage sites, or absolute iron deficiency, where there is actually a reduced availability of iron through reduced stores. This generally can occur in patients, for example, who are bleeding. Account bleeding is quite common in dialysis patients. Reduced intake of iron-rich foods are important factors. If we go to the next slide, we see that the data on undermanagement and underdiagnosis of anemia. This is data from Dr. Zhu and Dr. Wang and Dr. Farrington and colleagues. And what this data shows in quite a large analysis of patient data, 45,000, 6,705 million people, shown on the top panel, that about 26% of patients develop anemia in total. 15 of these receive a diagnosis of anemia, and about 19% of patients actually receive treatment. Of this 45,000, about 10% have severe anemia, and about 68% of patients actually have the diagnosis of anemia, and only about 43% of these patients actually receive treatment, demonstrating that there's both an underdiagnosis and an undermanagement. In the second cohort, you see that of about 6,766 patients, 40% of patients have a hemoglobin of less than 10 and have received anemia medication within a year. And on the right-hand side is data from over 5 million individuals. 20% of these individuals had advanced CKD with low hemoglobin. Less than 4% were treated with an ESA. And remarkably, iron testing was infrequent. So I think in aggregate, this data shows that there's a significant need in patients, an unmet need with respect to anemia in patients with advanced CKD. Turn to the next slide. What you see here is IV iron supplementation as a treatment. And as you recall in our case with Eugene, he had absolute iron deficiency as measured by a very low serum ferritin as well as a low TSAT. And in dialysis patients, because of the fact that absorption of iron by the GI tract is significantly impaired because of these high hepcidin levels, intravenous iron supplementation is necessary to supplement iron and to bring iron levels up and treat the anemia. But we have to balance risks with benefits. The first important factor is that intravenous iron overcomes this hepcidin-induced blockade of iron, both released from macrophages and those who have functional iron deficiency, but also it overcomes this block in reduced absorption of iron by the enterocyte in the GI tract. There are benefits of IV iron, and there are also risks of IV iron. The benefits shown here are, of course, you avoid absorption issues associated with iron being administered orally. And recall that iron taken orally does have side effects in of itself: bloating, sort of a tummy upset, black stools, nausea and vomiting are sometimes adverse events that have been noted in patients taking intravenous iron. The other benefits of intravenous iron in that there's faster and higher and quicker increase in hemoglobin levels. And at least in some populations of patients that have been looked at, particularly those with heart failure, there's improvement in patient domains of quality of life. On the other side, you see risks of IV iron. Some of these risks are actually hypothetical based on observational data, so you can rightly question the validity of this data, but some data has suggested that there's a higher rate of infections. In fact, in cell culture, if you take iron and infuse it into cell culture medium, neutrophils appear to function less well. But there hasn't been clear evidence that intravenous iron increases the risk of infections, more of a hypothetical risk. CV events also hypothetical. There isn't clear data that supports this contention, although it has been hypothesized. The data from the pivotal study that was published by Ian McDougall and colleagues actually put to rest some of these concerns. And then there is a risk of anaphylaxis, mostly in the use of iron dextran, where there seems to be an increased risk of anaphylaxis with rapid infusion of iron. If you go to the next slide, you see ESA treatment, and again, a similar approach of balancing risks with benefits. Some of these risks are clearly hypothetical, and some of them have been borne out from the literature. In general, we know that injecting patients with intravenous iron at dialysis or in non-dialysis patients by subcutaneous injection results in pulsatile erythropoiesis, because what you have is a sudden increase in erythropoietin levels, and then the erythropoietin level goes down. So the sudden increase in erythropoietin levels increases erythropoiesis in a pulsatile manner. There's also consequently a transient increased demand for iron, and it's possible that higher doses of ESA administered exogenously decrease hepcidin. And all of this may have some associated side effects. Shown on the left are the benefits. Obviously, treating with ESAs accords increased tissue oxygenation because of higher hemoglobin levels. There's some data that suggests increased or beneficial improvement in physical performance measured with standardized quality of life instruments and a lower transfusion rate. On the right-hand side, there are some risks. There's a risk of thromboembolic events. For example, there was a risk of higher rate of vascular thrombosis in patients that were evaluated in the normal hematocrit trial. This is a randomized trial published in the late 1990s that showed that treatment to a higher hemoglobin level in stable hemodialysis patients resulted in an increased rate of vascular thromboembolism. And Ian McDougall and others have shown that in patients treated with exogenous erythropoietin may have a higher risk of pure red cell aplasia. We're now going to spend some time on audience response. And the first question is, if Eugene was started on anemia therapy, what would be his risk of discontinuation at 12 months? And I'd like you to answer this question. So the answer for this audience response question is shown on this next slide, and you can see what the right answer is. Let's now discuss this. There is a risk of discontinuing ESAs. And shown here is a frustration by the patient index, if you will. About 30% of patients generally discontinue because they're not satisfied with treatment. About half of patients are dissatisfied because there's no or few improvements in symptoms. About 19% of unsatisfied patients report inconvenient monitoring requirements. About 15% report diminished quality of life, paradoxically, of course. And it's generally the case that there's a 12-month rate of discontinuation of anemia therapy of around 51%. This is data in non-dialysis CKD patients. The challenges with administration, of course, are subcutaneous administration versus intravenous administration. We know that subcutaneous administration, particularly of darbepoetin, is associated with increased stinging, which is often a frequent complaint by patients. And that home therapies are difficult. Caregivers frequently administer ESAs to patients, and so it's often inconvenient. Patients don't like injections, but caregivers also don't like. Let's look at treatment options, and here we are discussing different forms of intravenous iron formulations. And shown on this table are the formulations on the left, the dose in the middle column, and frequency on the right-hand side. And you see that you have formulations at the top end that include iron sucrose, and at the bottom of this table, iron dextran. The most traditional, oldest version of intravenous iron is iron dextran, doses of between 500,000 milligrams and at variable frequency. In iron dextran, many people will recall, is something that is a treatment that, unless you do it correctly, administer it slowly with a test dose, you may have associated risk of anaphylaxis, although the risk is relatively small. The newer ones are actually much more well tolerated, and depending on the contract the dialysis provider has, patients will be exposed to one or the other. They're pretty similar, except for ferrimoxytol, which can be administered very rapidly in an injection. In terms of expense, almost all of them are very similar in prices, except for ferrimoxytol, which is probably the most expensive, and iron dextran, which is probably the least expensive. If you go to the next slide, you see treatment options for erythropoietin-stimulating agents. The most common agent used in the United States right now is epoetin alpha, or epoetin alpha and with its analog. So epoetin alpha could, in dialysis patients, its analog is darbepoetin, and a pegylated version of epoetin alpha, which is epoetin alpha EBX, has also emerged as a approved treatment. And so these are the agents that are generally used among dialysis patients. In general, the things to know about these agents is there are black box warnings. We published a study called the CHOIR trial, which in 2006 in the New England Journal of Medicine. This was a study of non-dialysis CKD patients that was associated with a higher risk of patients among those who were treated to a higher hemoglobin. These were non-dialysis CKD patients treated with epoetin alpha. And there was an increased risk of cardiovascular endpoints and mortality, driven by mostly mortality and heart failure hospitalization, in the group where there was a target hemoglobin of 13 grams per deciliter and an achieved hemoglobin in that group with a higher risk of 11.3 grams per deciliter on average. The CHOIR trial resulted in a black box, but that black box really built on work that was published about 10 years earlier in the normal hematocrit trial, which was a trial in stable dialysis patients aiming for normalizing the hemoglobin, and reported again a higher risk of mortality or MI in patients treated to the higher hemoglobin. That study also reported a higher rate of vascular thrombosis. In the use of EPO in dialysis patients, it's usually given 3 times a week if it's EPO, and if it's darbepoetin, it's usually administered less frequently because it's extended half-life. Concerns about these drugs include a higher risk of malignancy. This was data that came from the TREAT study, where there was a higher rate of malignancy-related death in patients treated with darbepoetin alpha. This higher rate of malignancy was not shown in dialysis patients. But as I said, in non-dialysis patients in the TREAT study, there was a signal in a small subset of patients. There's reported to be a higher rate of hypertension. This is still controversial because in some studies, a higher rate of hypertension has not been reported. So it's a little controversial. But generally, the literature supports a higher rate of hypertension patients treated with EPO versus those not treated with EPO. And then there is this hypothetical risk of seizures and pure red cell aplasia that has also been raised based on a review of the literature. Looking at other treatment options, darbepoetin alpha, this has a black box warning that emanates from the TREAT trial. There was a higher incidence of stroke in patients who had a prior history of stroke. The rate was actually meaningfully elevated, and there was a higher rate of death associated with malignancies. These two risks were cited in the KDIGO guidelines with respect to the use of these agents. Darbepoetin can be dosed weekly or biweekly. In general, one point that you should note is that there's no difference in epoetin alpha or darbepoetin alpha with respect to efficacy, where efficacy is correction of hemoglobin. Let's move to the newer kids on the block. These are hypoxia-inducible factor prolyl hydroxylase inhibitors, or HIF-PHIs. These agents increase the uptake of iron and endogenous erythropoietin release. They also inhibit downstream effects of hepcidin. They may increase iron that's available for erythropoiesis by increasing intestinal iron absorption and decreasing iron sequestration. The effect of HIF-PHIs on hepcidin have been well noted, cause a decrease in hepcidin levels. But what hasn't been so clearly delineated is how and what beneficial effects of hepcidin result from this. It's hypothesized that there's increased absorption of iron and increased mobilization of iron in iron storage sites, but this has not been demonstrated as yet in any convincing fashion. These are oral formulations that serve to increase and improve the ease of use and convenience for home dialysis patients. And they may avoid issues associated with some of these treatments, such as infections, thrombosis, stroke, malignancies. Although in all the trials that have been done so far, HIF-PHIs have been shown to be non-inferior to conventional ESA. So we really don't know that they're superior to conventional ESAs in any of these domains. If we move to the audience response question here, the question is, which HIF-PHI treatments are available for use and should be considered with our patient Eugene? And you have the 5 choices that you can choose from. The answer is shown in this next slide, and it's C, protostat. And the reason for that is that's the only approved treatment in stable hemodialysis patients in the United States currently. Let's now turn to some of the data with respect to HIF-PHIs, and first focus our attention on roxadustat or roxadustat. They presented their data as pooled analyses from 3 phase 3 clinical trials. And these trials included Sierras, Himalayas, and Rockies, where they compared epoetin alpha in dialysis-dependent CKD patients to roxadustat. And the trials reported that roxadustat was non-inferior to conventional ESA, and cardiovascular outcomes also non-inferior to conventional ESA. And the table shows in incident dialysis patients and stable dialysis patients, the comparisons with respect to MACE, MACE plus, and all-cause mortality. And the only notable thing here is that among stable dialysis patients, there was a higher hazard for MACE, 1.18. It wasn't statistically significant because of the confidence interval from 1 to 1.38, but it's right on the border, and there's an 18% higher risk of MACE in these patients. And for all-cause mortality, the hazard was 1.23, a 23% higher rate, But here, there was a statistically significant increase because this confidence interval was 1.02 to 1.49. Because of this data and concerns about increased rate of thrombovenous embolism, roxadustat was voted down 12-2 by the US FDA for approval for dialysis-dependent patients, and it was also voted down again based on data from the Matterhorn trial measuring need for transfusion in anemia associated with myelodysplastic syndrome. Turning to vadadustat, there are two phase 3 trials, PROTECT and INNOVATE. PROTECT was in non-dialysis patients and INNOVATE was in dialysis patients. Again, the comparison was to darbepoetin alpha. And with respect to efficacy outcome, vadadustat was non-inferior to darbepoetin alpha. The cardiovascular outcomes failed to demonstrate non-inferiority for PROTECT, which was the non-dialysis study, but was non-inferior to conventional ESA in the dialysis study, INNOVATE. The most important concern that was raised by the US FDA when they reviewed vadadustat was the lack of non-inferiority in non-dialysis patients and a signal for drug-induced liver injury. When you look at the time to first MACE for vadadustat compared to conventional ESA, here darbepoetin, you see that for PROTECT, it was 1.01 to 1.36 was the confidence interval, so it failed non-inferiority. And for INNOVATE, it was 0.83 to 1.11, and it met non-inferiority. So vadadustat was not approved by the US FDA, but the NDA has been resubmitted for patients on dialysis, and a decision by the FDA currently is pending. Last but not least, let's talk about the ASCEND clinical trial program. ASCEND-D was a phase 3 trial of 2,964 patients that compared daprodustat to darbepoetin alpha. The daprodustat dose of 4 to 12 milligrams tablet orally administered in dialysis patients. These were stable dialysis patients recruited after 90 days of initiation of dialysis. We're looking at, there were two efficacy outcomes, correction of hemoglobin and MACE. And for both, daprodustat was non-inferior to conventional ESA. And as I just pointed out, conventional ESA here was darbepoetin alpha. And when you look at the data here for both hemoglobin and MACE, the two co-primary endpoints, you see that daprodustat met the criteria for non-inferiority. And indeed, the drug was approved by the US FDA on 1st February 2023 in CKD patients on dialysis. Here they defined stable dialysis after 30 days of initiation of dialysis. So the only approved drug in the United States among the HIF-PHI class is daprodustat, and that for stable dialysis patients. A trial that was done in the ASCEND trial program, ASCEND-TD, looked at trying to simulate how this drug might be used in stable dialysis patients. And here it was looking at, again, comparing with darbepoetin at the conventional ESA. The dose was 2 to 48 milligrams, given 3 times a week. So it's very similar to how you would administer it in stable dialysis patients. And again, hemoglobin was looked at to see if it met the non-inferiority criteria. And it indeed was non-inferior. Daprodustat was non-inferior to conventional ESA. And it appeared to be, on further analysis, significantly higher response rate with daprodustat compared to ESA in this population. There was no significant difference in incidence of adverse events, although there was a higher rate of stroke in patients treated with daprodustat. When you look at and compare daprodustat with conventional ESA, you see the responder analysis, and you see the adverse events very similar, broadly speaking. So let's turn our attention back to our patient case, that of Eugene. As you recall, he's a 65-year-old African-American who presents to you with questions around treatment with erythropoiesis-stimulating agents and adjusting for iron supplementation. And the questions are, what do we need to consider when choosing treatment options for Eugene? As we discussed based at the very beginning on his iron data, it's clear that he has depleted iron stores, as evidenced by a low total ferritin and low TSAT. And so the most immediate need here is to supplement Eugene's iron stores. And the correct treatment there would be the use of intravenous supplementation. And the choice of agent will really depend on what's approved by your institution or the contract with your dialysis provider. But in general, you want to give him intravenous iron because there's a block in oral iron absorption in patients, and very little of the oral iron, if you administer it orally, would actually work in this patient. What should be the goal for Eugene? Guidelines would say get his hemoglobin above 10 and below 11 if it's in the United States, and between 10 to 12 if it's in Europe. In general, Eugene is not going to be able to just have increased iron therapy. You're going to have to think about his ESA therapy. He receives therapy most likely on dialysis 3 times a week. But because of his home dialysis status, you may want to consider use of a HIF-PHI, and the only one that's approved in the United States is daprodustat, and can be administered by himself, self-administered at dialysis. It works, as evidenced by the Ascend TD trial data. What counseling needs to be done with Eugene? Clearly, there are a couple of things one would consider. Important things are to make sure that he's eating well, so he's at least being able to replete his iron. You want to make sure he's not getting frequent blood draws, and his dialysis system isn't clotting frequently, so there's no blood loss occurring, because clearly there seems to be some source of iron loss in him. You'd want to counsel him on how to use daprodustat. The fact is that daprodustat, if you decided to use that as his treatment, you need to tell him that he needs to monitor his hemoglobin the same way as hemoglobin is monitored with conventional ESA, and aiming for a hemoglobin level of between 10 to 11 grams per deciliter. Let's now turn our attention to SMART goals. This acronym stands for specific, measurable, attainable, relevant, and timely. In our discussion today, I think we've emphasized the importance of understanding the unmet needs of patients regarding underdiagnosis and undermanagement of anemia in CKD patients on dialysis. We've thought about how we utilize this knowledge of the benefit and risks of iron supplementation of ESAs and HIF-PHIs in treatment of anemia in CKD patients during our decision-making process. And then I think we've all also discussed the importance of implementing the clinical data from trials of these novel HIF-PHI treatments, and with respect to treating eligible patients. These are patients in the US who are stable on dialysis with anemia of CKD, who can benefit from oral therapy. We've seen from the data from the Ascend D trial that any dialysis patient could benefit from oral therapy, but probably the sweet spot of patients are the ones on home therapy, those on home dialysis or peritoneal dialysis. So let's now conclude. Today's CMEO briefcase is part 2 of a 3-part series of case-based activities. I hope you'll check out the other 2 activities in the series. To receive CME or CE credit for this activity, participants must complete the post-test and evaluation online. Participants will be able to download and print their certificate immediately upon completion. Be safe and take care of yourself so you can provide the best care for your patients. And I want to thank you again for your attention. Goodbye.